if you have questions and you want to post them into the chat, you can go ahead and do that as well. And so between Dr. Sinda and I will try and keep an eye on the chat and keep each other informed of who's asking what. So Dr. Sinda, I don't know if you want to take a moment and just introduce yourself to the group, and then I'll follow suit, and then we'll get started.
Okay. Hi, everyone. I'm Dr. Rich Sinda. Welcome, and thanks for popping in. This is really casual, kind of informal. We want everybody to feel free to hop in and ask a question whenever they want. Any question is fair game. Hopefully we'll know the answer, may not. We can at least take a good stab at it. I've been a physician for 30 years now, coming up on 30 years. I now have a functional medicine and hormone replacement practice, but I do a lot of functional medicine in conjunction with that. And I did extra training in functional medicine. And then I was trying to find a way to get more of that in my practice. So I learned a lot more about the functional medicine of dementia prevention and early dementia treatment. Found out there was just tons going on the cutting edge of dementia prevention and early dementia treatment. Crazy, cool, and very intriguing, tremendous opportunities out there now to improve and restore memory and prevent dementia. So yeah, welcome everybody. Feel free to hop in and ask a question. Go ahead, Guy.
So my name is Guy Odishaw. I'm the owner of Baki Wellness Center and partner in the Minnesota Brain Health Clinic with Dr. Sinda. And I too have been practicing for 30 years. I did not know that we had that in common, Dr. Sinda. My area of specialty within the Minnesota Brain Health Clinic is the bioelectric medicine, and in particular, neuroimaging, neurofeedback, and neurotherapy. It's kind of the primary areas, but then do a little branching out around the edges of that. But that's what I'm here to talk about today, is any of the technology side of what we do in the clinic. And I'm hoping that all of you had a chance to look at our presentation. And if you did, then you'll have a better understanding of what Dr. Sinda does in the practice, what I do in the practice, and our roles will be clear. And if you haven't had a chance to watch this presentation, that's just fine. It'll be there for you later. But let's go ahead and just open up the floor if folks have questions. One of the questions, I see that there, Dr. Sinda, is what are some of the new treatments for dementia within the last few years? So would you like to take a swing at that?
Sure. What is new within dementia treatment in the past few years? Well, it depends which realm of medicine you're talking about. So what is new on the research front? What do the cutting edge scientists and neurologists doing research, what are they finding versus what is being prescribed or recommended in mainstream clinics? Unfortunately, the latest and greatest in mainstream medicine is still pretty bleak. And even the latest drug that came out last summer it's not very hopeful, even though it did get FDA approved. 3 people actually left the FDA because they were so disturbed that it was approved because it did not show any real benefit. So the tradition of dementia treatment has been bleak for a long time. It's been a series of failed single therapy or dual therapy drugs like Namenda and Aricept that really at best have very minimal improvement, at worst have a lot of side effects or even make people worse. So new front, as far as new approaches go, they're finding that, not surprisingly, one drug is not going to be the answer. It's going to be, first of all, you have to find out what is the underlying trigger of the dementia. Is it insulin resistance? Is it chronic inflammation? Is it some type of chronic infection? Lack of hormonal nutrition, hormones or nutrients. What is the underlying trigger? And then, first of all, you have to look for all of that, which isn't being done always and often isn't. You have to find out what those problems are. And then after that, obviously, when you find something that's off or wrong or needs treatment, that you actually treat it. Sadly, the things that you find most of the time are not that obscure, not that unusual, but they're not really being looked for or treated. So, and what Dr. Bredesen and his team in California found is that there are many opportunities to stave off dementia or treat it when it's early, but you have to find out what those things are first, and you have to do a pretty extensive workup to find these things. And there are several things, like let's say somebody has a magnesium deficiency, a B12 deficiency, and a testosterone deficiency, and a thyroid deficiency. And let's say you don't even look for two of those, or you treat them very ineffectively. If you don't treat them adequately, you're going to still be at risk for dementia. So that's in a nutshell. So really, to what is new, it depends whether you're looking at mainstream medicine or whether you're looking at on the cutting edge science end of things. And that's what Dr. Bredesen is all about. He's trying to bring the mainstream science.
And I would say from my side, I think some of the, the newest, even within the Bredesen protocol, which is itself new and kind of, he's working kind of to keep it ever fresh. But I would say the technology side is where some of the biggest things are happening, right? The mainstream medicine has the medications. And if you're kind of following what's happening, they've got the latest medication kind of in the dementia Alzheimer space, and they're just getting pilloried for even considering bringing it out because of it's so ineffective. So I mean, on one end, you could say, well, that's new, but I don't know, we should be too excited about that. Then you have what you have with Bredesen, which, not to say there isn't new in there, but it's a lot of it is kind of the tried and true of lifestyle medicine. Right? And so just bringing it into that space and showing its efficacy. Then again, on the new side is bringing something like the near infrared light and the research showing the efficacy of near infrared light to dramatically affect the disease process. So not just treat the symptoms, but be able to address the fundamentals of the disease itself, which could be in some cases, and again, we have to allow there are different subtypes of the disease, and they have different etiologies. And so if we pick something that is, say, like mitochondria, we look at there's a mitochondria kind of a root cause, and you're able to treat the mitochondria and get the mitochondria functioning again, then that's a root cause, or that's a treatment of the root cause of the disease versus just treating a symptom. So I think that's one thing that is new. The research, there are it's probably a good solid decade of it. What I think stops it from really kind of grabbing the mainstream is there just isn't the size of studies. Like, we aren't seeing multiple studies with hundreds or thousands of people, but we are seeing hundreds of studies of 5 to 10 people. So there is a significant number of people, but done in these kind of small studies, and some of them are placebo controlled, but many of them are not. So it's really the stage that the research is at, but I think the research that's out there is solid. Microcurrent therapy, which is another approach to it, I think the research there is okay. I think also the problem with the transcranial electrical stimulation is it's going a little bit more after the symptoms than the cause, whereas the photobiomodulation is going more for the cause of the disease. MIT's study that came out about 3 years ago now, showing the reversal of Alzheimer's using photic entrainment. So that's another one that is using a technology. Here, we're not actually putting light transcranial into the brain. We're using the optic nerve to increase gamma oscillations in the brain. And then there's the trail of how gamma oscillations affect the microglia and the role microglia play in the onset and progression of the disease. So if we can affect it on that level, they've actually been able to show the ability to reverse the disease. So To me, that's where some of the most exciting stuff is happening, is in that technology space.
You know, and that reminded me, there is something I definitely forgot to mention related to what I was talking about too. You know, there have been kind of they have rediscovered in looking for effective things that help nurture brain cell health, you know, rediscovery of like lion's mane mushroom, berberine, you know, turmeric, curcumin. Those many of those things are incredibly powerful for brain health as well, and those are definitely off the mainstream radar. And but like you said, Guy, and I did mean to emphasize this too. Lifestyle is, you know, incredibly important, as you know, as we all hear every day, all the time. So there's no surprise there. Tweaking the way we eat and what we eat to improve insulin sensitivity and diminish insulin resistance, that's huge. Exercise, adequate exercise, healthy, solid, you know, good quality sleep, that's, you know, invaluable. So yeah, that those are definitely true as well. The other thing I would say is one of the problems that Dr. Bredesen's run into so much is that the standard of science, that everything has to be a randomized, double-blind, placebo-controlled study. That really only works, as I talked about in my lecture, it really only works for one variable or one or two variables. Once you get to three variables, it's not useful. And we're talking about a situation where you have 42 variables that can influence your dementia risk. And you know, and certainly one of the best things that for us is we found that altering your lifestyle, altering the way you eat, altering your supplements, and adding the bioelectric medicine modalities, you know, that's found to be one of the most effective things, ways to approach dementia. So that's how we, you know, got together in the first place. We just saw the incredible potential to marry the biochemical side to the bioelectric side. And Dr. Bredesen is encouraging that too, and he's seen incredible results adding the bioelectric medicine to the lifestyle piece and the supplement piece. So that was a long response. Hopefully everybody's still awake, or their battery didn't die on their computer.
Do you feel like you've got a response to that?
I'm sorry, I missed the question.
Oh, okay. I wasn't sure if you were reading it in the chat.
No.
So would you say because some root causes of dementia is being missed, dementia can be misdiagnosed, and it is something as healthcare workers we can do? I'm sure, but
Absolutely. Oh, go ahead.
yeah, I was just gonna ask for maybe just a little clarification. I kind of feel like there's two parts to that question. One is just around the misdiagnosis, like that's
Right.
one thing, and then the
Right.
other being the part of that is anything healthcare workers can do. I'm assuming about the misdiagnosis side of it.
Right.
That was
One of them is, as a patient, or if you are the relative or the caretaker of the patient, whether you're their spouse or their daughter or whatever, you can demand that extra testing be done. Are there, you know, false dementia that's caused by B12 deficiency and untreated hypothyroidism? Yeah, but that actually can lead to real dementia. So it's not false dementia, or it's not like a misdiagnosis, but those things can actually increase your risk of getting real dementia, real Alzheimer's disease, because lack of nutrients and lack of, you know, uncontrolled blood sugar, out of control insulin levels, untreated hypothyroidism, untreated B12 deficiency, those things all increase your risk for getting actual Alzheimer's. So they're kind of co-diagnoses. They're not, it's not a necessarily misdiagnosis, but they're missing that is a risk factor for you to develop actual dementia. So that's a really interesting question though. I mean, yeah, and it's it's a very interesting question, but really they go hand in hand. That's why it's so important to look for all these things, because these are all the things that are going to put you at risk for real dementia. So, you know, that's one of the biggest points of all of this. Right. So excellent question. how does one get the tests needed to determine the cause? Most doctors don't want to do them. Yes, and that's what our program is about. Where Dr. Bredesen talks about there's 42 holes, which really means there's 42 potential, obvious, risk factors for dementia. So you look for those. Maybe a third to a half of them have been done by regular docs, but not always. It's really, that's one of the values of the program, is that you look for all 42, you check all 42 factors, and wherever you find a problem, you have an action plan to treat it. Luckily most people don't have 42 things wrong, or even 39 things wrong. They have 6 or 7, or when it's really bad, if we're lucky, they only have 4 or 5 problems, and then our goal is to fix the issues that we find, and then find a way to wake up brain cells, and and turn them back on and get them rolling, and that's from the bioelectric side. So yeah, so that's one of the values of the program. The Bredesen people will come to your home to draw the blood too, and then they ship it to through Quest or something to do all the tests necessary. A couple of the tests are very complicated and expensive, and actually it's much cheaper to go through Dr. Bredesen's program to get them than to do it just piecemeal. The actual cost of all the tests is lower than if you did them one by one through a lab.
And it might be worth saying, and this is actually kind of a question for you, Dr. Sinda, if you kind of agree with this, but also if you feel that how Dr. Bredesen presents it, if you feel like he agrees with it. But my sense of it is these neurodegenerative diseases, they take so long to come on, right? The trajectory of them is maybe 30 years back. And then, being a little more conservative, you could say certainly 15 years before there's definitely a significant clinical signs and symptoms. You're about 15 years back. The actual diagnosis can't be made until autopsy, when you can look and see, right? So kind of seems like we're pulling together as many pieces that kind of indicate that this is likely what's happening. And it's like that. So that, combined with the fact that the progression of the disease has such a long history to it, I think this is part of why we see the misdiagnosis, is so prevalent in the broader healthcare system. Is it isn't something you can just do a blood test for, and then it tells you, you have plaques and tangles, or
and you get your one pill to fix it.
Yeah,
and you can't get your one pill to fix it. It's not going to be like that.
Yeah. So it is a challenging condition to really, to diagnose and to really say that this is, because of course there's when it's severe enough that the symptoms are relatively obvious, but the goal is that's too late, right? We want to pick it up. Again, ideally, if we say that we've got a 15-year history here, we want to pick it up 14 years earlier. And that's the question of how, right? And that's, I think, one of the things that the program so valuable is all of the pieces that are brought together to kind of create a profile to give a strong indication that this is likely the case, right? And that's about as firm as we can get. I mean, even in the part that I do, where we do the neuroimaging, right? We can't say, it's not diagnostic of the condition. We can only say this is suggestive of the condition.
Well, if there are really obvious cases, but when it's subtle, it's really tough. Yeah. It also takes a long time for that anatomy to change once you get an effective program in place.
Yeah, which is I guess the other side of it too, from a treatment standpoint, is I think not always do the folks who are looking at engaging a program, do they, if they're far enough along that they're showing symptoms, again, they might be 10, 15, 20 years of of the degenerative condition happening before they express that symptom. And then they start treatment, and there can be that sense of, well, hey doc, it's been 6 weeks, how come I'm not better?
Yeah.
And I think that's another thing we need to, to appreciate about this is we're trying to ideally reverse many years of degeneration. And that isn't going to happen quickly necessarily. Right? But I did see another question pop in there.
So they're asking so do you think doctors should prescribe mental exercises such as memory games or games like Sudoku along with their medications to help delay progression of their memory loss? Sure. I mean, anything you do to exercise your brain can't hurt, right? I mean, now as far as the hard science showing that that's crazy effective,
Not really.
but boy, it's hard. You're hard pressed to think that it wouldn't be at least in some way be a positive, right? And just like exercising your biceps is going to make your biceps tighter, right? I mean, your biceps aren't going to get more developed or tighter or more lean if you just sit around the house on the couch all day, right? But if you do even gentle exercises, you're more than likely going to get better biceps, right? So, I mean, it just is logical that anything you do to challenge your brain is going to be helpful at, strengthening or restoring connections. But as far as the hard science behind it, there's a lot of arguments over that right now. But, I can't imagine that it wouldn't be. Besides, it's fun a lot of times anyway. So.
Well, I will say, again, you're right. I mean, there isn't definitive research, but if we look at what we do have and kind of weight it, so the problem with the brain is it's an efficiency engine, right? It's always heading towards efficiency. So let's say you do Sudoku and that's your chosen thing. Your brain is learning every time you do it how to do it more and more efficiently. In other words, how to recruit less of the brain to do Sudoku. And that's exactly the opposite of what we want here, right? When we're trying to spare lost synapses and neurons. So the better suggestion is actually novelty, playing a variety of games. So not just doing puzzles or even a variety of puzzles, because again, the brain will figure out how to do puzzles with the least amount of neural activity to complete a puzzle. And so it's novelty. And one of the best things that you can do is actually like going out into the world. So you're moving your body, you're using all of your senses and move through novel spaces, right? So going places you haven't gone before, going to a park, going to a museum, going to a historic building, wherever, but going into the outside world, three-dimensional space, having to navigate it and have that be novel, that's one of the best things that you can do, because that recruits the most amount of neurons and synapses to do that activity. And so you get the complete opposite of what happens if you do, say, a crossword puzzle, and you always do the crossword puzzle, then your brain is diminishing how much it fires up to do that activity, versus novelty recruits more of the brain. So novelty is really the key factor you're looking for. And then doing something that involves more of the body just means it involves more of the brain. So those two things in combination. But again, I'm with you, Dr. Sinda. It's better than not doing it. But the research does show that only doing something like lumosity or some of these things does not get much, neuronal activity. The brain's too smart for that.
So, learning new things like instruments or new languages, I'm sure that's, again,
Yes.
there's no downside to that other than that it takes time. But I saw something interesting once that was saying that people who drive themselves to work, the challenges and the multitasking or the having to shift your attention around and your, that itself was a brain workout. And I was used to driving in downtown Minneapolis, so boy,
That'll do it.
It felt, it was precarious. It was, I mean, it was, felt dangerous at times. I mean, just because of the crazy drivers and the heavy traffic, so you have to keep on your toes, that's for sure. Yeah. So anything else?
Yeah, do we have any other questions out there? We've got a couple of things that we could cover, and then we can call it a night. I prepared just a little kind of before and after for one of our Bredesen patients, just to show some of the results of their progress in the program. So we could spend a moment with that, and then we might want to talk a little bit about, this process that we're going to be doing this on a somewhat regular basis. And then we have a live event, another live event coming up in March. I'll pull up Keynote here and go into my slides. Jackie posted a question: how does one get started with the program? Excellent question, Jackie. So typically what would happen is, a person might start, if a person hasn't kind of sat through this, if they haven't watched one of our presentations, if they're completely unfamiliar with the program, we'd start them off with a just like a 15-minute phone consult with Dr. Sinda to just kind of go through the program, find out if they're a good candidate. And if they are, then we would book them for an in-office or virtual consult with Dr. Sinda, where he kind of goes through the initial questionnaires, get some background and a better understanding of where a person is at, explains the program, and then if all of that it sits well with the person who's kind of still kind of feeling out the possibility, the next thing they would do is do a either in-person or virtual consult with me, where I would talk through what I do with the neuroimaging and how that kind of factors into their overall evaluation. And at that point, the patient would make a decision. If they decide to sign on, then it's back with Dr. Sinda to go through the full intake, to get into the Bredesen system, fill out the paperwork, start the process of labs, come see me for doing a QEG or quantitative electroencephalograph and an ERP or event-related potential neuroimaging. So basically kind of the process of collecting all of the data from health history, lab, and the neuroimaging. And then they'd follow up with a consult with Dr. Sinda to go through their information, a consult with me to go through their information. And then at that point, we kind of set out, what is a treatment plan going to look like? And, we really try and do our best to meet the patient where they're at, try not to overwhelm with all of the possibilities of what can be done. The program is quite extensive, but find out what makes sense as a place to start for that person. And then they can layer on, because again, this is really a lifestyle program. And so they can layer on those layers as the months go by, the years go by, and really customize it for themselves. But it starts with that initial consult with Dr. Sinda, either a phone call or an in the office, to really find out about the program in detail and if any one person is a good candidate for it. So I'm going to just switch over to, so what we're looking at here is, so the particular type of, this is our neuroimaging QEG, and what I do. We're looking at what's called peak alpha frequency, a very well-known metric in the brain. It's understood of what it does and what happens when it's on and what happens when it's off. So we're looking at here on the left, the before and present time on the right. So if you look at the map on the right, you'll see this kind of gray background. So that's what we want to see. So basically, no color is good, color is bad. Right? Color equals a finding, right? Something is off compared to the normative database. So this patient's brain is being compared to an age and gender matched normative database. And this is showing us how far off the database are they. And basically colors like red, the warm colors, are saying too much, and the cool colors are saying too little. So we can see that this person, really, you could say, like, this is a brain on fire in the before. And if we look at the present, it's much better. And so this is, again, we're looking at the neural correlates we have for this patient, also their subjective reports and the reports of coworkers and family. And there's been a really dramatic change in function for this person. And so we're happy to see that in the reports, of course, but seeing it in the labs just helps to validate that the change is happening objectively. And so we can see that here. Go to the next one. So this is called Microstate Dynamics. It gets very into the weeds, but it's one of the gold standards for Alzheimer dementia evaluation. And what we see here in the before is this leftmost head map. So this is a little head. It's got a little nose, little ears on the side. This is a head map. Again, we can see there's a lot of excess activity here. And then the other two are not bad at all. But when we look over to the present time, we see that first head map is almost clear. So again, this is a dramatic change. I'm going to show you just a couple more. And we see our before here. This is kind of a summary map, a lot of information on these pages, but I'm just going to touch on them. If you look here in this first column, you can see both the color changes in these first two heads, compare the present time to the before. And things are moving towards normal. But here, the connectivity maps. This one right here, the blue kind of spaghetti head in the middle here, that is telling us that there is a lot of miscommunication happening, under communication. There's asynchrony and so information processing is going to be very poor. If we look at that same brainwave frequency, the coherence measure in the present time, you can see that that's greatly decreased. So we know that this brain is processing information in a much better. And then the last one here in the lower left corner, again, kind of what we call a spaghetti head. There are just so many connection issues. This is really a compensation pattern. This is a brain trying to make up for the lack of communication that's happening. So it's kind of revving its engine. And we can see that that has settled down immensely in the present time maps. So again, a pretty dramatic change. And here, this is kind of a comprehensive look. You want to look at this kind of from a distance and just generally see that the present time maps here on the right, you see a lot more of the gray, which is the background, which means the brain is functioning equal to the normative database. Right? And that's kind of just in a very low resolution way. That's what we want to see. We want to see a brain moving back towards the normative database. And we see here, so these are broken out into individual frequencies, right? So ranging from 1 to 20 hertz, with this up in the corner being 1 hertz and this down here being 20. So we see across the different frequency bands, this brain is moving back towards normal functioning. And then here, we're just, again, kind of going now from 21 to 40 hertz. And you can see all of this excess, right? So we call this inflammation, right? So neural inflammation is settling down, and we're seeing a much calmer brain. Now we are seeing kind of this green, which means too little. And so that's still a significant finding, but it's much less concerning than what we're seeing here with these dark oranges and yellows, that the inflammation that was happening. And so this was a great kind of objective finding to match the subjective change that happened in this person's life and their functioning.
And can I, so you, and you said this probably, I was looking at the dates, but now you said, so this was after neurofeedback and audiovisual entrainment. So he got intensive brain therapy, right? Intensive brain therapy, bioelectric brain therapy on your side, and on my side, I worked on his blood sugar and insulin resistance, and he was dramatically improved. He was noticeable by his wife and his coworkers, dramatic improvement. And he was very alarmed at his cognitive decline before this. And And the first images you show Guy are him when he was very concerned, and his wife and his coworkers were all very concerned. And he's back to leading the meetings now, where they couldn't even let him talk anymore. At one point, he couldn't hold his thoughts together. So
Yes, yeah,
dramatic. It was dramatic.
it was dramatic, and I would say
Clinically as well.
that
I mean,
I would, from my side, I would say the kind of change that we saw from a neurofeedback standpoint is dramatic. It's not the kind of change we typically see in 20 sessions, right? And so I have no doubt that his changes, like his blood sugar, getting blood sugar under control, working on the insulin resistance,
yeah,
that was probably the number one factor. And then that allowed the work that I do to be able to work. Like I could reach the brain, because the brain wasn't just always on fire and we weren't fighting the glucose.
right.
And so it was definitely, I think is a great example.
But also, I honestly believe him being able to function better, like what you were doing, was helping him follow the program to get his sugars under control too. So it's going to be really one of those, which came first, the chicken or the egg, but it doesn't matter as long as you get to a good place, right?
Right.
So.
And I will say, as you said, this was a person who was highly motivated. We, kind of bit off more of the program than maybe many of the folks do.
Yeah.
And in particular, on my side, on the bioelectric side, I mean, from day one, he jumped on the audiovisual entrainment and started reporting positive results from that really right out of the gates. He was, improved sleep and started to find that memory was improving. And so, there was a good amount of time spent on that, and then into neurofeedback, and things did pick up the pace in terms of improvement with the neurofeedback. So yes, I mean, I think it's a great example of the two sides of this program, the potency that they create. So
very complementary, amazing complementary. They complement each other so well. That's really why we got together. I mean, we just saw the incredible potential for complementary approaches. Dr. Bredesen talks about it in his lectures. When I was doing the training, he goes into a few lectures just talking about the power of bioelectric medicine and complementing his approach. So yeah, very powerful.
So if there are any questions about the bioelectric side, the summary that I just showed, feel free to ask them. If there are other questions, great. If not, then we might be just at a point where we can talk a little bit about what's coming next and call it a night. What we can say is that we're looking at doing a monthly kind of Q&A, and we want to wrap that into a kind of a Q&A and coaching session for folks who are in the program and want to be able to check in and just chat with both Dr. Sinda and I, but also their fellow Bredesen people, so that we can just kind of share what people are doing, what they're finding successful, but also for people who are interested in perhaps joining the program. It's just, so we just want to do a monthly call that's going to be kind of like tonight, kind of an informal conversation, Q&A, some coaching. And then we're going to do another live event, like we did the October 28th event. It'll be at our building at 7550 France in Edina. And we'll get that date out to the folks who are attending here tonight and to our whole email list.
Anybody have any last minute questions? Real quick or anything? Yeah, what I would say is, why aren't we doing this everywhere? Yeah, that's the question. We should be. That's the problem. We're not when we should be. And that's Dr. Bredesen's point too. He's written a few really good books too, if you guys are interested in learning more about what we've been talking about, because there's a lot there, but it's really a fascinating adventure he's been through, and a fascinating process but they're called The End of Alzheimer's, and it's Dale Bredesen, MD. If you're interested. So yeah, so anything else, Guy?
Nope, I feel like we
we covered it, I
We
think.
covered it, and I want to
Yeah.
say thank you for everybody that
Yeah, thanks,
made
everybody.
time to come join us.
Yeah.
It's been a delight to chat with you, although kind of somewhat literally in the chat.
Thank you,
Yeah,
guys.
thank you. This was great. We appreciate you guys taking the time and walking through this. This is good.
Thank you. Thank you, guys. Take care.
All right.
Good evening. Good night.
Good night.
Thanks, Guy. Take care.